Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy. Pathology. There's a pretty basic formula to this that maybe we can go through in between one of the cases, but let's jump into it.
All right. Dexter, I guess you're up, or who's?
Okay.
All right. So you have a 15-year-old male presents to your clinic with pain radiating from the anterior maxilla. He says that it's been present for the last 2 months. It's getting worse. He reports some swelling and some shifting of his maxillary teeth. What would you like to know next?
I'd like to obtain a complete history of present illness, including long onset, location, duration, characterizing, aggravating, and alleviating factors. And then I would like to obtain a medical history, a surgical history, allergies, medications.
Yeah, sure. So past medical history, pretty just consistent with hypertension. I'm sorry, with depression and bipolar disorder. He had a tonsillectomy at 4 years old, no drug allergies. He's taking some SSRI for his depression. He's in a kind of in an institutional place right now. He's going through a manic crisis. His mom is out of town, so he's a little bit by himself. He's with his dad, but he's with his caretaker. He comes to the appointment. So as far as we mentioned, pain has been present for 2 months. He doesn't really know what's going on. That's pretty much it. What would you like to know next?
Just as a side note, is the dad able to consent for him?
Mm-hmm. Dad is able to consent for him virtually. So can you walk me through clinical examination?
I'm sorry, can you repeat that?
Can you walk me through the clinical examination?
Sure. So I'd start with a scalp to clavicle exam that would include inspection, palpation, percussion, and auscultation. I would do a brief TMJ exam, and then I would perform an intraoral exam, examining the dentition, the occlusion, and then I'd perform an airway exam, including opening, Mallampati classification, and neck range of motion.
Okay. Yeah. So your exam pretty much shows no facial swelling. You got this intraoral mass that it's present on the upper right maxilla between the teeth number 7 and 6. There's mobility of teeth number 7 and 6 and percussion sensitivity. There's no active drainage. What kind of imaging would you?
I'd like to start with the CBCT.
Okay. Yeah. So you got a panoramic X-ray with a CBCT. What do you see?
So this is a 3D orthopanogram reconstruction of a CBCT. The condyles are seated in the fossa. The sinuses are clear. There does not appear to be any missing teeth. At the between teeth number 6 and 7, there's splaying of the roots, and then in here in a axial view of the CBCT, or probably an arch view of the CBCT, you can see a mixed radiolucent, radiopaque lesion of the anterior maxilla.
What's your clinical diagnosis as far as what's some of your differentials on this?
So a differential diagnosis would include OKC, squamous adenogenic tumor, ameloblastoma, and mucoepidermoid carcinoma.
So what do you want to do?
I'd like to start with a biopsy of the lesion.
What kind of biopsy?
I would do an incisional biopsy.
All right. So so how would you do incision biopsy?
I would make, so I'd like to begin by aspirating the lesion with an 18 gauge needle.
Okay. So you decide you're going to go ahead and take the whole thing out. So you pretty much go ahead and open everything up, and you kind of look at this thing, and it looks mostly like a CGC. You end up taking tooth number 7 and 6 with it, and your final path comes back as a CGC. As far as central giant cell granuloma, can you tell me about how can you, as far as histologically, can you differentiate this from a brown tumor?
You cannot.
Okay. How can you make sure this is not a brown tumor?
You would want to do a parathyroid hormone workup.
Okay. So what labs would you check?
Parathyroid hormone and parathyroid stimulating hormone.
All right. So you basically take this thing out, and you follow up with a patient for a couple of months, but he's lost the follow-up. He comes to your clinic back looking like this. What do you think is going on?
This appears to be a recurrent CGCG.
Mm-hmm. All right. And what are some of the conservative treatments for this as far as a larger lesion like this?
This is an extensive lesion that appears to be extending into the nose, into the maxillary sinus, and a maxillectomy would be indicated.
Mm-hmm. Mom doesn't want a maxillectomy. She wants to know if there's any other conservative treatments.
Medical management includes serial steroid injections and calcitonin intranasal.
Great. So you go ahead and you administer all that, and the patient does better, and you end up doing the maxillectomy and the recon with the fibula. So next case, you got a 52-year-old female referred by the general dentist evaluation of a right cheek mass. Dentist reports that it's been watching it for the last 6 months, thinks it's hyperkeratosis, secondary to trauma, but it's not improving. He wants a second opinion. What would you like to know?
I'd begin with the history of present illness.
So hypertension, pretty well controlled, history of uterine cancer, she's in remission. She had a cholecystectomy done. Everything else is pretty patent. She does not smoke, never smoked, no history of any smoking, tobacco products, or alcohol consumption. Really nice lady. Can you walk me through a quick clinical examination?
So I'd start from a scalp to clavicle exam, including percussion, palpation, inspection, and auscultation. And then I would move to an intraoral exam, examining the dentition, examining the lesion in question, and I would perform an airway examination. Okay.
So you have this endophytic mass, ulcerated mass of the right buccal mucosa extending to the vestibule and the mandibular ridge. Mass is pretty firm, and tooth number 29 is percussion sensitive. Your neck examination, there's no nodes that you can palpate. There's a little bit of mild swelling to the right mid phase. You end up getting an X-ray as well. Do you see any changes, anything concerning on this orthopentagram?
So this is a 3D or a planar reconstruction of a CBCT with incompletely visualized condyles. Sinus are incompletely visualized. Missing third molars, missing lower posterior teeth with expected bone loss. I don't see any gross abnormalities.
Sure. All right. So, what would you like to do with this patient?
So I'd like to begin with an incisional biopsy.
What's in your differential?
So my differential would include oral squamous cell carcinoma.
Okay. So you go ahead and you do the incisional biopsy. Comes back as invasive squam, well differentiated, depth of invasion about 2.5 millimeters. You tell the patient pretty much the findings. Can you tell me about some clinical labs and workup? What would you do for the patient to work her up for surgery?
So my workup would include a history of present illness that was completed. a H&P, previously completed biopsy, which was
what imaging and labs would you order for this patient?
So I'd like to get a CT of the head and neck with contrast. I would like to get a CT chest without contrast. For labs, I'd like to get routine preoperative labs, including CBC, BMP, as well as nutrition labs. If the patient is diabetic, I'd get an A1C.
All right. So you got a chest X-ray. It's clear. There's nothing going on. You also get a PET CT. Can you tell me what a PET CT is?
A PET CT evaluates metabolism of a anatomical site.
Do you know what the tracer is?
It's a radio-labeled glucose.
Okay. All right. And do you know any of the scan guidelines you would tell the patient prior to sending them for PET CT?
I do not.
Okay. All right. So how would you treat this? And can you go ahead and give me your clinical stage and your TNM staging for this?
So a 2.5 centimeter with a depth and invasion of it was 2.5.
2.5.
2.5 millimeters. That would be a T2 clinically negative neck, which would be N0, and then M0.
Would your actual clinical TNM classification change if you had cortical resorption and active cancer in your alveolar crest?
Yes, that's a T4.
Okay. So you go ahead and what's your surgical plan? How would you complete this?
My surgical plan,
as far as ablative and recon.
My surgical plan would include a two-team approach, including resection and reconstruction with microvascular free tissue transfer.
What kind of flap would you use?
I would use a fibula.
Okay. All right. So what's your dominant vein and artery for the fibula?
So it's the perineal artery and the vena comitans.
What pre-op imaging would you order to make sure that patient is a good candidate for fibula free flap?
I would do a CT evaluate for 3-vessel runoff with angio.
All right. So you talk about all your options with the patient, and she's like, "Doc, I can't do this right now. I got to take care of my sick husband that's dying. He's in a hospice." So she comes back to you looking like this. What do you think is going on?
So they have progressive oral squamous cell carcinoma.
She has
extensive disease.
All right. What would you stage this as? She has positive nodes bilaterally. You
Stage
did
4.
She has some lesions underneath her trachea. So
Stage 4.
Okay. Good job, man. That's it. You walked through it pretty good. Yeah.
Thank you. It's good cases.
Yeah, man, you did awesome.
That was pretty good. Solid on both sides by my end.
Yeah, so this is typical cases that I've seen through clinic, but actually just being now in a private practice. But anyway, so the first kid, 15-year-old male with just this mass of the anterior right maxilla. It's basically it came back at CGC. So, as far as CGC, I forgot to ask you about what subtypes of it. That was one of the questions. I guess you have non-aggressive and aggressive. And in this case, this would have been an aggressive type, and it would fall into minor because it's a rapid growth, but it's less than 5 centimeters. And there is clinical displacement of the teeth and cortical resorption. So another question I forgot to ask, I was trying to get you through both cases, would be what is the prognosis for reoccurrence with enucleation, curettage, and extractions of the teeth? And for aggressive types, it can vary from 20 to 30%. So close follow-up is definitely recommended on patients like this. You got the Brown's differential diagnosis right as far as checking for PTH levels, as far as your surgical plan. Obviously I ended up excising the whole thing and taking the teeth out in clinic, and followed him for a while, and he was fine. But as far as recurrence, if it does recur, it'll recur within the first 2 years, and you really want to make sure you follow up closely. As far as clinical management, for conservative management, you're dead on. Steroid injection, calcitonin, 100 units for 6 months, and then seeing if it improves, and then you can try it for another 18 months. And then interferon alpha is another option. If this thing shrinks, then you can do a partial maxillectomy. I didn't get a chance to ask you about what Brown's classification this would be, and obviously this is just a scan that I found online, but it's mostly like I would say a Brown 3 to Brown 4 ablative defect after surgery. And then for the second case,
I gotta sharpen my swords for the oral boards. I learned them from Patel, and he's the Lord, and I'm his protege. You know I'm gonna slay all these motherfucking questions today, cause I got the sound bites. They're gonna make these old men go ooh ah like some afternoon delight. Yo, I got these questions in my sight, and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.